The Genitourinary Cancer Research and Treatment Center was created to improve the quality and efficiency of care that we provide to our patients.
Our primary focus is kidney cancer, but we also focus on bladder cancer, prostate cancer, testicular cancer, and any rare cancers that may crop up around the genitourinary organs. Gives us an opportunity to use our expertise for rare cancers that may pop up like a sarcoma.
For the most part, GU cancers are detected once a patient develops a symptom of the cancer. There's one exception, and that is prostate cancer. Prostate cancer is the most common non-skin cancer, roughly 180,000 cases in the United States per year, and right now is still most commonly picked up on routine screening PSA blood test.
In terms of kidney cancer, a lot of those are found incidentally. There's not a blood test for kidney cancer. Likewise, bladder cancer doesn't have a screening test, but if you have any blood in your urine at any time, whether you can see it or whether your doctor detects it, then it's important to be evaluated by a urologist to find out what the cause of that blood is, because that may be the earliest warning sign for someone with bladder cancer. Genetic testing is typically offered after the diagnosis to help patients and their loved ones understand their risk for future cancers and to understand what possible treatment options may be available to them.
Once a cancer is detected, the patient needs to meet with a cancer specialist. In the Genitourinary Cancer Research and Treatment Center, that would involve either a medical oncologist, a urologist, or a radiation oncologist, and in some cases they meet with all three of us. We would want to make sure that we have diagnosed and staged the cancer appropriately, and after that is done, we can have an educated discussion with the patient regarding various treatment options. Many of these treatment options involve multiple types of therapies. We meet regularly and have tumor boards where we bring all the medical specialties together and try to individualize the most effective treatment plan for the patient.
Traditionally, a patient would come into my office and I would see them and I would make a recommendation or a treatment plan, but the opportunity with the multidisciplinary care team is such that I can make a treatment plan, but I can also hone my treatment plan to be the best possible care for that patient by involving other service lines earlier in their care so that all the doctors involved in the care are on the same page and using guidelines and evidence-based medicine for our patients.
At the end of the day, the most important lifestyle change would be just to eat smart, to eat a healthy, balanced diet, and to exercise regularly.
Everyone should quit smoking. 100% my recommendation would be to quit smoking. Tobacco products in general are not good, but smoking specifically increases a woman's chance of bladder cancer by 11 times and a man's chance of bladder cancer by 5 times. The only known risk factor for kidney cancer, other than a genetic syndrome, is smoking. So that smoking is the most easily modifiable risk factor for GU cancers. It's not easy to quit, but I've recommended any number of things: nicotine patches, lozenges, hypnosis, anything to quit smoking would be great. Some people who have these kind of cancers live with these cancers for years, if not decades. And so we're managing those diseases, and we sometimes lose sight of the other things that are important, like heart disease. And so just a healthy, low-salt diet may be their best bet. But in general, smoking is your best and most important risk factor to modify.
We have several large clinical trials that are ongoing and currently recruiting patients. Many of these therapies may actually raise the bar even farther, hopefully curing more patients. Some of these therapies may be known to people, such as immune-based therapies, where we're able to harness the patient's own immune system to do the work of going out and destroying the cancer cells themselves. Other trials involve novel therapies. Many of these therapies are pills where people can take in the convenience of their own home. It has been truly a blessing for us to have been involved in the development of several new therapies that have received FDA regulatory approval in the United States for cancers such as kidney cancer, a cancer in which prior to 2005 there was no effective therapy.
Starting back over a decade ago, Dr. Hudson was a leader in kidney cancer, and the first drugs that were ever developed to treat kidney cancer orally were developed in part on this campus where we accrued patients. That leadership has continued, and so we have numerous clinical trials available for patients who may have high-risk cancer and no obvious disease right now. We may have options for patients who have bladder cancer that's multiple occurrence but not invasive, and so they may be looking at a major operation, and there may be some other options that we can use as a clinical trial to maybe delay their need for a major surgery. So we have numerous clinical trials, and those are available through our website.